Good day, everyone. I am Peter, your moderator for this webinar on the behalf of the organizer company called Conference Panel. I welcome everyone for today's webinar, which is called CMS Hospital Surgery, Anesthesia, and PACU Conditional Participations Requirement. So now, I would like to introduce our presenter for today, Sharon Courage. Sharon Courage is a registered nurse and a master's in public health. Ms. Courage has 30 years of experience in hospital quality and risk management, quality improvement, development of hospital programs, patient safety, and acute and long-term care. So now I would like to hand over the floor back over to our speaker. Over to you, Sharon.
Thank you very much, and welcome everybody. So today we're going to be talking about some of the CMS conditions of participation. We're going to be focusing on surgery, PACU, and anesthesia services. So first we'd like to look at what some of the deficiencies are in surgery from a CMS perspective. And then required OR equipment is 9. Then we're going to be talking about anesthesia services. And then for your PACU, surgery and PACU deficiencies. So we're going to start with talking about surgical services. You conform to aseptic and sterile technique. AORN temperature, if you choose them, is between 68 and 73 degrees, and humidity is between 30 and 60%. Impact of lowering the humidity. Lowering humidity can impact some of the equipment and supplies. Organization and staffing, 941. Standard OR must be supervised by an experienced RN or a doctor, MD or DO. Circulating RN. Okay, we're talking about surgical privileges. Bylaws must have criteria for determining privileges. You must specify each practitioner that performs a surgical task, including MD, DO, dentists, oral surgeons, podiatrists. Have to have policies and procedures, and so here are some of the policies and procedures I was talking about. So here is an environmental cleaning toolkit. So here are some more surgery policies. And then here is a policy on preventing wrong site surgery, comprehensive surgical checklist. So malignant hypothermia, and malignant hypothermia, you have to remember, is anywhere in the hospital. Preventing OR fires. So preventing OR fires is a big process. So there's a lot of information here about presenting OR fires, and I went over all of this. So just here are some things that are pretty scary. An OR fire and the OR. Patient seriously burned from an OR fire, an AORN fire safety toolkit, fire safety videos. Yeah, so I talked about the solution soaked. History and physical, 952. Documented assessment requirements. So a policy, it would, some of the things that you would consider, and this you'll see this under tag A at 362 as well. Informed consent. Informed consent is in 3 sections of the conditions of participation. It is under surgery, it's under medical records, and it's also in patient rights. So informed consent, obviously the name of the hospital, name of the procedure or treatment, the name of the responsible practitioner who is performing the procedure. There is no requirement anywhere for an anesthesia consent. However, anesthesia is a procedure. So most hospitals would like, and most anesthesiologists want to have their own consent. So you have the policies we talked about, who may obtain informed consent. So you want to make sure that that's really clear who can get it. You have to have an OR register. Immediate post-op note, and this is your operative report, PACU. Post-operative care unit. Care must be consistent with acceptable standards of care, include same-day surgery patients. Post-op monitoring, concerned about post-op patients receiving IV opioids, so at higher risk for oversedation and respiratory depression because they have just gone through anesthesia. American Society of PeriAnesthesia Nurses has some information around that. Pre-anesthesia, PeriAnesthesia nursing standards around that. So I'm going to go to anesthesia now. Anesthesia involves administration of medication to produce a blunt, what they call a blunting. Analgesia is the use of medication to provide pain relief through blocking pain receptor in peripheral and or central nervous system where the patient does not lose consciousness but does not perceive pain. So there is no bright line when medication moves from analgesia to anesthesia under some circumstances. So these are definitions for general and regional anesthesia. Monitored anesthesia care. Moderate or conscious sedation. Topical or local anesthesia, again, is not defined as anesthesia. Rescue capacity. One anesthesia service. Anesthesia services must be organized into one service. Services under qualified director must be under the direction of an individual who is a qualified MD or DO who can administer anesthesia. Regulation 482.52a establishes qualification and supervision requirements. Nursing services. Personnel assigned based on specialized qualification. Reevaluation at QPI. You must have periodic reevaluation of policies and procedures. So anesthesia can only be administered, so this is 1001. State exemption. So there are some states that may be exempt from supervision from CRNA. Administration of anesthesia. Unless in an opt-out state, you must be supervised by operating practitioner doing the procedure and proper supervision of anesthesia services. A federal QTAM whistleblower lawsuit was filed by former anesthesiologist and Professor Dr. Dennis O'Connor, who was investigated by the U.S. Department of Justice. May administer anesthesia under the direction of an anesthesiologist, so this is your assistant. MS bylaws, rules, and regs must include criteria for determining anesthesia privileges. Supervision of operating surgeon. Services must be consistent. Pre-anesthesia evaluation must be completed and documented within 48 hours prior to surgery. Pre-anesthesia assessment must be done by someone qualified to administer an anesthetic. At the end of the 48 hours, delivery of the first dose of medication for inducing anesthesia. So that's how they do that time frame. If you see a patient on Friday for Monday, you must show that on Monday there were no changes to that patient. So elements required within 48 hours. Elements review and update within 48 hours. Intraoperative anesthesia record. You must have policies that ensure each patient has an intraoperative anesthesia record. Intraoperative record must contain patient name, hospital ID, name of practitioner, who administers anesthesia, post-anesthesia. Oh, so here is the typical anesthesia record, manual anesthesia record would look like. The post-anesthesia evaluation. So a post-anesthesia evaluation needs to be done for anybody who has max, general, regional, and deep sedation. Must be completed as required by hospital policy and procedures. Completed and documented within 48 hours for general, regional, and deep sedation and max. 48 hours starts at the time the patient is removed into the PACU. Elements of an adequate assessment. Critical access hospital. Anesthesia standards overall. Anesthesia standard C1144. Pre-anesthesia assessment is performed prior to in or outpatient surgery. Must be done by qualified practitioner. Must have a post-anesthesia follow-up report on all patients. Elements of the assessment. Administration of anesthesia. Supervision of CRNA, same as with the hospitals. Supervision of AA. So I just want to thank everybody for attending, and it was, hopefully it was helpful and will help you with your work. Thank you very much.
Thank you, Sharon. Thank you, participants. So with this, we conclude the session for today. Thank you so much for joining today's webinar. Have a great day.